Good morning, and thanks for the opportunity of, let's say, discuss this relatively new technology that, to be honest, and let me disclose this, that it took almost a year to convince me about the opportunity of using regularly in the cath lab. Now, I'll try to show you just an example, because honestly, I changed my presentation this morning because I took off all the slides related to the physiology for bifurcation, all the discussions that we've done over the last day and a half. So I said, okay, let's start from the case and see what do you think. So, medical history, hopefully you can see it. Okay, so relatively, well, nothing special, I would say. Former smoker, hyperlipidemia, obesity, hypertension, in the 60s, a male. So with some prostate hypertrophy with previous episodes of major urinary bleeding. In the last 2 months, chest discomfort at rest. So it was admitted in the emergency room with prolonged chest pain, and the label was non-STEMI because some rise in the troponin. The echo showed mildly reduced ejection fraction with hypokinesia of the anterior lateral wall. So, of course, right coronary, can we play it? No, let's go back. No, sorry. Can you run the right coronary for me, please? Is that possible? Okay, nothing special, but just wanted you to see that there was some kind of diffuse disease here and there, but nothing special, of course, especially because it was not consistent with the findings of the echo. But this is the left system. As you can see, there is a tight stenosis in the LAD, but very, very short, and a couple of other stenosis, one obviously involving the proximal big D1 with a, honestly, I would say very long diffuse disease, but also a couple of disease in the marginal. Can you run it again, please, for me? And the other one too? Okay. So, obviously, we decided to have a look at the bifurcation to the proximal LAD, and that was the results. So I'm not sure how many of you colleagues are familiar with CathWorks, but the very first thing that you have to do with the CathWorks, which is basically an angio-based FFR, which has been, well, actually demonstrated as good as the invasive FFR in the FAST trial was about to be published, is to do first the coronary segmentation, meaning that you have this color code, which doesn't mean anything in terms of physiology, but it's important for the software, which is non-invasive, of course, for actually understanding the true significance of every single segment at a time. So, in other words, in 3 projections, you analyze the entire left system in 3 projections. So, obviously, the focus was on the LAD. And as you can see here, we also have a color code for the physiology. Red means this is positive. Indeed, you can see 0.6 to the distal LAD, but also you can see the numbers and the colors related to the other branches, all the other branches at the same time. Diagonal was significant, as you can see, because it was orange. Orange means that is positive as well. Also, the CathWorks is able to give us the volume of the myocardium that is having an FFR less than 0.8. Also, it is possible to have other information. Where is exactly the drop in the pressure, and is obviously consistent with the anatomy that we've seen from the angio. It also gives us the information related to the lumen, and the narrowing of the artery, as you can see, of course, is pretty much consistent. So I did a PCI. So that's my strategy. We can discuss the details later on. But then I started with a non-compliant balloon, slightly undersized. And then with the cutting, again, slightly undersized, but then I use a Prevail 275 according to the measurements done with the CathWorks. And then that was semi-compliant balloon to the D1, and then again at the Prevail 225 for this angiographic results. I hope that you can see. Can you run it again, please, for me? So angiographically, I would say I was quite happy, but then I said, okay, the tool is there, and I do it again. So this is, again, the distal LAD FFR angio 89. But also you can see there is a 0% of the volume of the myocardium subtended by the left system, 0% had FFR less than 0.8. So you can see that the colors is very, very bright yellow for the LAD and yellow for the diagonal, meaning that the job has been done, well, probably in the right way. This is a comparison head-to-head, pre and post. In other words, doing the projections that I had to do anyhow, I had also the possibility to evaluate the physiology, which is, at least in my practice, paramount in order to better understand whether we can leave the result that we obtain with the balloons or possibly we need to work more. Because we can discuss, forever, what is the right indicator or parameter to select a good or acceptable angiographic result. Nevertheless, if we have physiology telling us, look, you have fixed the ischemia, there's no more ischemia, then we can discuss about the section, we can discuss about the angiography, we can discuss about everything else. But to be honest, I think that if you can do this for the patient, it's a good thing. Patient has been discharged in DAPT for 1 month. I know the patient was non-STEMI, but this is our practice. We try to minimize the duration of dual implanted therapy, even in the case of ACS. Well, where are the data? You tell me afterwards. Asymptomatic so far. So far so good. I will do the CT scan for this patient. We don't do regularly follow-up angio. We use photon counting CT scan for these patients. And I have to say that in the view of minimizing the invasiveness, starting from the cath lab, using the CathWorks instead of a wire, I believe that using coronary CT scanned follow-up might be a good idea, depending on the availability of the tools. These are my conclusions. Side branch intervention still remains the Achilles heel of PCI. In the bifurcation in particular, CathWorks allows a meaningful evaluation of the true need for a treatment and can be used to immediately assess the results without doing anything more than you have to do anyhow. Full DCB approach is possible. There is still a long way to go. Thank you very much.